Welcome to the latest MS Hear from the Experts webinar. This series is helping people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate your MS journey with more knowledge and confidence. Our intention is to help you learn more about this disease, treatments, research, wellness strategies, our programs, and much more. I'm Shauna McKinnon. I've had MS for a little over 25 years now, and I'm going to be your moderator for today's broadcast. So I'm pretty familiar with almost all of the topics that we've covered so far in this series. Now, before we get started with our presentations, let's briefly go over a couple of housekeeping items. First of all, your microphones have been muted, and they're going to stay muted for the entirety of the broadcast. If you do have a question, you can type it into the chat box, and we'll try to get to as many questions as possible following the formal presentation. Please note that questions pertaining to very specific personal situations likely cannot be answered in this type of venue, and we do recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. The session is going to be recorded and is going to be available soon on our website in English. We're also adding French subtitles to the recording, but that version won't be available for several weeks. The recordings will be available on our website under archived webinars, and on our YouTube channel. A Facebook Live recording is also going to be available. Please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but it provides information to assist individuals in making their own health and wellness decisions. Today's broadcast is an opportunity to learn more about enhancing your wellness by getting treatment for your MS-related fatigue, plus addressing health issues that can contribute to your fatigue. Fatigue can be one of the most disabling symptoms of multiple sclerosis, and research shows that over 80% of people with MS experience fatigue either as a primary symptom due to active inflammatory disease or a secondary symptom that could be caused by other medical conditions, heat, medications, stress, depression, and possibly sleep problems. So during this webinar, you're going to learn what MS fatigue is and how it affects your life, plus treatments and strategies to help reduce and manage your fatigue. Today's expert is April Royal. She's a registered nurse with a Bachelor of Science in Nursing and holds a master's degree in education. As an MS nurse, she has worked in the MS field in a variety of roles for over 20 years. April is currently working in the Barlow MS Centre at Toronto's St. Michael's Hospital as the project manager of education, but she continues to support MS clinical research trials. She's also been involved with MS Canada and several pharmaceutical companies to develop and deliver MS-related education. So please welcome today's expert, April.
Thank you, Shauna. I'm going to talk about MS fatigue tonight and look forward to, hopefully you'll have some questions that you can send forward. So the subtitle of this tonight was The Invisible Disability. And people I know get frustrated so often by you're having a day where you just feel awful and somebody says, oh, but you look so good. And it really has the effect, I think, of undermining what you're having to endure. So why this subtitle for this? There's so many invisible disabilities in MS, that things that people just don't see. Bladder problems, sensory disturbances, and fatigue of all of them is the big one, the biggest, as Shauna mentioned, and probably the most difficult to handle. So our plan for tonight, we're going to talk about what is MS fatigue, how does it impact life with MS, and what are some strategies for managing it. Fatigue isn't unique to multiple sclerosis, although it does seem to be somewhat disproportionately an issue in multiple sclerosis. It's been reported to affect about 80% of people with MS at some point through the journey of their MS. It's the most commonly reported symptom, and it's often the most troubling, and in fact accounts for disability and not working. Sorry, it's not quite big enough for me. Some facts about fatigue in MS. It can be characterized by it's not proportional to exertion. So it's not because you can say, well, I just, ran around the block and now I'm feeling tired. You can't pinpoint a cause of it. It's present on waking after a full night of sleep when you should be feeling refreshed and yet you're not. It can come on very suddenly, and it can be worse with heat and humidity. As I said, it's been reported to impact 80 to 90% of all people with MS at some point. It tends to be more pronounced in progressive disease than in relapsing disease, so later on in the illness. And interestingly, it seems to affect men and women equally. It's very complex to study fatigue because people experience differently. It's very subjective. They describe it differently, and people's tolerance for energy varies. So what's MS fatigue? I really like this, Snoopy. I feel like I just need to lie down for a couple of years. I think that sort of says a lot. Fatigue is not the same thing as being tired. Tired happens to all of us, and tired is when we've had a busy day after certain activities, and at the end of the day, we're just pooped. But a good night's sleep fixes the problem. Usually, you know why you're tired. MS fatigue isn't that way. It's a daily lack of energy. It's unusual or excessive whole body tiredness that's not relieved by sleep. It can be what we call acute, where it lasts for a specific period of time, maybe a month or less, or chronic, where it's going on longer, from a month to 6 months or even more. The challenge with fatigue is it really can prevent you from functioning normally, and it affects everything about your quality of life. So we have primary MS fatigue and secondary MS fatigue. Primary MS fatigue occurs as a direct result of the inflammatory changes in the central nervous system that are a consequence of the MS disease activity. There are some studies that have suggested that it may relate to the additional effort used by the central nervous system to adapt and to navigate, to do the things it needs to do around the areas of MS damage. Secondary MS fatigue can occur as a result of contributing factors, and there are many of these: sleep disturbance, mood and cognition problems, and general deconditioning. Why is it important to take a look at these specific things? Because identifying the contributing factors is going to be key to helping build successful strategies and interventions. There's also fatigue that everybody can get, related to medical conditions like anemia, arthritis. So on top of having to deal with MS fatigue, whether it's primary or secondary, as life goes on and as we get older, there are other things that can add to the burden of fatigue. So it can be a very complex thing to sort out. So how does it impact life? It's really complex. So, we have the inflammation and structural changes that we've talked about. Pain makes you tired. It's exhausting, actually. Bladder problems that keep you up all night, so you're not getting a decent night's sleep. Anxiety is a very common thing in MS. Sleep disturbance through sleep apnea, and mood disturbances. So all of these things, fatigue will actually aggravate them, and it becomes a kind of a vicious circle. So what are the costs of fatigue? Obviously, loss of enjoyment in things that usually bring pleasure, missing out on family and social events. And I think something to keep an eye on is that this tends to not be very black and white. It tends to be slowly incremental, where you find that, over time, you're just doing less and less of the things that you like. It can strain family and social relationships, people who have expectations for you, who feel that you're not living up to them because you're not kind of getting out there and you seem to just want to rest all the time. Fatigue can present cognitive challenges. All of us, our cognitive functions don't work as well when we're tired. It can cause difficulty meeting work and family obligations, and in particular, broken promises, and those really stress important relationships. It's also a leading cause of unemployment in MS, so particularly in younger people. This was an interesting study that was done in the UK looking at multiple sclerosis fatigue. So they recognized going into this that fatigue is widely experienced and it's incapacitating, that it hinders daily functioning and has a deleterious effect on the quality of life. The UK MS Register has over 20,000 people registered in it. So this is a really big study. And the aim of the study was to estimate the prevalence, predictors, and impact of fatigue on people with MS using this data. What they came up with was that fatigue is a common symptom among people with MS. Depression, longer duration of MS, secondary progressive MS, and high EDSS can predict fatigue. Fatigue had an adverse effect on physical activities, mobility, psychological well-being, and quality of life for people with MS. That just validates in a scientific way what we know. So let's get in a little bit now to the strategies for managing fatigue and improving things. Identifying and managing these contributing factors may improve things substantially. We may never manage to get rid of the fatigue entirely, but it may be possible to improve it to a much more tolerable level. Sleep disorders in MS are extremely common. I think this is something that's only relatively recently being looked at in a serious way. If we look at sleep-related breathing disorders or sleep apnea, this is present in 6.3% of the population and about 20 to 60% of people with MS. Insomnia is about 30% of the population, and about 15 to 55% of people with MS experience it. Restless leg syndrome, 5 to 10% of the general population, and roughly double that for people with MS. So these are all things that are keeping people with MS up at night, and we all know if you don't sleep well at night, you're not going to feel too energetic the next day. Some symptoms of sleep apnea, and I'll talk a little bit about this because it's so common and it's so treatable. Snoring, pauses in breathing, gasping, choking on awaking, non-restorative sleep where you wake up just not feeling you've had any sleep at all, excessive daytime sleepiness or fatigue, again, cognitive disturbances, and nighttime awakenings. Now, this is one of those things that your spouse will know and you won't. So if they're telling you that they're noticing this, it's worth taking note because, of course, when we're sleeping, we're not aware that we're doing these things. This is an ongoing discussion in my house. There are two kinds of sleep apnea. So obstructive sleep apnea, and that tends to happen as people get older, as they put on weight, and it's related to the structures in our upper airways during sleep. As you sleep, things relax and they don't tend to be as taut, and so they cave in a little bit. So OSA relates to these structures kind of narrowing the airway in a sense, and it's one of the most common disorders encountered in the general population in terms of sleep disturbance. Current studies suggest that the prevalence of obstructive sleep apnea is even higher in people with MS, with estimates ranging from 20 to 50%, most of whom remain untreated. And when I say something recent, this is something that the Barlow that we're starting to do a lot of, sending people for sleep apnea studies. And the reason is that can be so readily treated. Central sleep apnea, though, involves repeated, complete, or partial reduction of airflow due to intermittent lack of respiratory effort. So this is caused by the structures within the central nervous system, in the brainstem, motor, and sensory networks. The exact prevalence of this kind of apnea in MS is still unknown, and several case studies have been done to take a look at it. It would suggest that people with MS, particularly those who have brainstem involvement, or the more disabled patients, are at elevated risk for this. The treatment of sleep apnea, I'm sorry, this sort of showed up in the wrong place. CPAP, or continuous positive airway pressure, is the gold standard for the treatment of obstructive sleep apnea. And what this does is it keeps just a little bit of pressure so that your airways, as you exhale, don't collapse completely. And it's remarkably effective. It keeps you breathing properly and keeps the rhythm and the cycles of sleep going in a normal pattern through the night. Sorry, I'm just trying to read this. Oh, and it is as beneficial in people who have MS as the general population. So this is something that is really well worth pursuing. Insomnia, difficulty falling asleep, staying asleep, or waking up earlier than you want to wake up. I say insomnia can be contagious because, somebody who's up walking around the house at night or flipping and flopping in bed tends to keep other people awake too. So this can be just more than an individual problem. It causes a lot of clinical suffering, and it can impair social and educational professional life and other important domains through what it does to your cognition and not sleeping at night. The sleep disturbance associated daytime symptoms definitively occur at least 3 times per week. So if you're having at least 3 nights a week where you're having trouble sleeping, that actually qualifies as insomnia. The disturbance has to be present for at least 3 months. And we're not talking here about, the kind of insomnia that's reactive to something, a trauma in the family, a worry about something at work. We're just talking about the plain inability to fall asleep and stay asleep. It happens even though you have lots of opportunity to sleep, a comfortable bed. It's just, you just can't fall asleep. Insomnia is not caused, this insomnia is not caused by the physiological effects of a substance. So if there are alcohol and drug issues, this is not the kind of insomnia we're talking about. Those are things that are relatable. This is insomnia really of no known cause. Coexisting psychological and physical diseases don't explain insomnia either. If the criteria for insomnia are met in context with a psychological or physical disease, those things need to be treated, and that in turn should treat the insomnia. Contributing factors for insomnia, not a big surprise: worry, stress, anxiety, things that are not uncommon in multiple sclerosis. Some medications, particularly steroids, which are so commonly used in MS, and in fact at the Barlow, I think quite commonly a sleeping sedation is prescribed for people who are on a course of high-dose steroids for their exacerbation. It's important during an exacerbation to get some rest. We give people steroids and they feel all ramped up, probably better than they felt in quite some time, but it's really important to get that rest, and those sleeping pills are really important. If the need to go to the bathroom is keeping you up every couple of hours all night, it's completely impossible to get a decent night's sleep. If you're suffering pain or, tingling, burning sensations in your limbs, that will interfere with your sleep, and spasticity, that tightness of the muscles that can happen in MS. So all of these things, as you look at them, are things that actually can be impacted with an intervention. If we look at treating insomnia, a careful history to identify the contributing factors and treat those as needed. Optimizing sleep hygiene, that's our routines around going to bed. And medications may help, but because of the long-term nature of MS and potentially of MS insomnia, it's not a long-term solution. We need to get at other ways of falling asleep. Medications are useful for the short term and particularly in times of stress. So what are good sleep routines? Going to bed at the same time each night, allowing for 7 to 9 hours of sleep, sleeping in a cool, dark room. There's one doctor who says there's only 2 things that should go on in the bedroom, and TV isn't one of them. So just having a sort of a quiet time to settle down and sort of soothe into that nighttime sleep should help promote a more restful sleep. Limit alcohol intake and completely avoid alcohol after dinner. It actually does work as a stimulant. It makes you sleepy initially, but as it kicks into your metabolism, it works as a stimulant. Avoid caffeinated beverages. Caffeine lurks in all kinds of things, including colas and chocolate. And it's best to avoid those afternoon if you can. The caffeine in tea is significantly less, but even tea and even green tea has a little bit of caffeine. No screen time before bed. So I'm one of the worst ones for this. I think I'll just check this one more email, and 30 minutes later, I'm still scrolling through things and looking and having this light shining in my eyes. There's an interesting study that looks at the impact of screen time at bedtime. So meta-analysis is where they take all kinds of studies and they try to pull out similar findings in the individual studies. And this one looked at the effect of portable media devices, so phones, iPads, etc., on sleep outcomes. So this meta-analysis looked at 20 studies, and they wanted to answer the research question, what's the impact of a portable media device at bedtime on sleep? So looking at inadequate sleep quantity, so not having enough sleep, 6 studies addressed this, and they showed a 79% increased risk of inadequate sleep quantity with the use of a media device before bedtime. Another outcome looked at the quality of sleep. 4 studies looked at this, and this was a 53% increased risk of decreased quality of sleep. And then finally, excessive daytime sleepiness. 3 studies addressed this, and screen time before bed meant that you had more than double an increased risk of having excessive daytime sleepiness when using one of these devices before bed. Restless leg syndrome, RLS for short, can be related to nothing known at all. It just happens. Or it can be secondary, arising from damage to central nerve pathways in conditions like spinal cord injury and multiple sclerosis. It's defined as a restless or uncomfortable sensation in the lower extremities worsened by rest and inactivity. It has a tendency to occur in the evening or before bedtime, and it's relieved with movement. So you can imagine you're trying to lie there and get to sleep, and your legs start going, and you can only settle it down by moving. It's kind of counterproductive. Treatment requires investigation into possible contributing factors like nutrition. Some medications can cause this, and sometimes medication can be helpful in settling that down. Bladder dysfunction occurs in up to 80% of people with MS at one time or another. And this is a challenging one because it tends to be one that people don't talk about. It's embarrassing, it's awkward. And so people tend to, unless directly asked, they don't even mention it to their doctor. MS lesions can block or delay the transmission of nerve signals in the areas that control the bladder and the urinary sphincters, or the kind of like the doors on the bladder system. And it's really, really common. A spastic or overactive bladder that's unable to hold the normal amount of urine, or a bladder that doesn't empty properly because it can't contract properly, keeps some urine in it, can cause symptoms that include frequency or urgency of urination. You have to go too often, or when you go, you gotta go. Hesitancy in starting a stream, and frequent nighttime urination, also called nocturia. Bladder is tricky because it has many control sensors, both in the spinal cord, in the brain, and in the bladder muscle itself. The management of bladder dysfunction. If it's a sudden onset of bladder dysfunction, check in with your GP, because things like a brewing infection can certainly kick that off. An assessment by a urologist for the cause can be very helpful. They'll do things like measure how completely your bladder is emptying. Is it emptying completely, or is it, as I said, not emptying and contracting properly so that you're still having urine left in the bladder and then it fills up that much more quickly? So you're always playing catch up. Medications may be helpful in relaxing the bladder muscles and allowing them to stretch out and accumulate a normal amount of urine. Intermittent catheterization can also restore full continence for people in many cases. And I've seen it used even just before bed, so that before bed, a person can catheterize, it empties their bladder completely, and they're good for the night. And this can make a really big difference. Let me just go back to that for 1 sec. I'm sorry. One thing to keep in mind, that is a scary thought, intermittent catheterization. But it's actually not even a sterile procedure. It's a clean procedure. You can do it in the privacy of a bathroom, and it takes no longer than a normal bathroom break. It's pretty straightforward, and people take to it pretty quickly and pretty easily, particularly given the relief that it can bring. Mood and anxiety as a cause of sleep disturbance and fatigue. We know that a low mood can make you feel generally tired and down. It's a bit of a chicken and an egg too, I think. Mood and anxiety can kind of feed each other, and one makes the other worse, and it just keeps going and going, and sometimes you need something to actually to break that vicious cycle. Depressive disorders are very, very common in MS, and up to 50% of people living with MS will experience a significant depression at some point in the course of their illness, whether it's at diagnosis or some life milestone event. But there's a good chance that it's going to be something that people will experience. The prevalence estimates, so how often it happens as compared to the general population, is about 2 to 3 times higher. And we know that depression in general is not an uncommon thing in the population at large. Many factors can contribute to depression MS. There are biological mechanisms. There's some thought that the inflammatory process that goes on may be creating chemicals and byproducts that can trigger depression. Lesion burden and regional atrophy, the areas of the brain that are getting some shrinking and experiencing the MS plaques, that can be predictive of depression depending where they're happening. The stressors, threats, and losses that accompany living with an unpredictable and often disabling disease like MS. Talk to your GP. This person probably knows you best. There are things that they can do, we will talk about that in a minute, to help. And again, it's something that people tend to not talk about. For some reason, there tends to be a sense of failure attached to experiencing depression. We're very hard on ourselves that, I should be able to kick this, I should be able to rise above this. But there are very real chemical and physical reasons why depression is such a common thing in MS. And there really isn't a need to suffer in silence on that one. And certainly we know that depression makes fatigue worse. So managing depression, psychotherapy is talk therapy, and it's been shown to be a very effective treatment for clinical depression, either by itself or in combination with medication. For severe depression, it may not be enough by itself, but it certainly can play a very important role when used with other treatments, including these medications. It's used to help people find the ways to deal with everyday stressors. It can support using your medications properly. Studies support the idea that therapy can be a powerful treatment for depression. Some have also found that combining depression medicine and therapy is effective. And a large-scale trial involving more than 400 people with treatment-resistant depression, so depression that didn't respond to drugs, found that talk therapy alongside the medication really helped improve symptoms. Why treat? Why bother? And I think this is a really important part of dealing with MS in general. It's keeping you in the driver's seat. So going back to that notion that it's about failure, it's not. It's about noticing that something's wrong and taking the steps that you need to take to try and make things better. This treatment and therapy can help ease the stress. It can give you a new perspective on problems. It might make it easier to stick to treatment. You can use it to learn how to deal with the side effects of medication. You can learn ways to talk about with other people about it, including family and those fragile relationships that really feel this and can be damaged by it. It also, in terms of talk therapy in particular, can help catch the early signs that your depression is getting worse and that whatever you're doing is not working. Time to try another tact. Approximately 50 to 70% of people with MS will experience pain of some sort. And this pain, there's such a wide variety of pain syndromes that it can be, but we'll talk about some of the common ones. Headache and migraine has been shown to be more common in the MS population than the general population. It tends to occur in people who are younger with shorter duration of disease, and most commonly it presents as migraine. Optic neuritis is another common pain. Sometimes this is the first experience that people have with their MS, and this is an inflammation of the optic nerve, and it can cause pain in the eye, either constant gnawing pain, stabbing pain, or just with eye movement. This pain will improve as the exacerbation recovers. Sometimes it's a reason actually all by itself for steroids, because the steroids and optic neuritis can really settle down that inflammation and bring relief of pain quite quickly. Back pain's another really common one, and this is often related to the problems people have with gait, caused potentially by weakness on one side. So if your right leg is weaker, your left leg is, you're kind of tilting your gait, tilting your balance to to accommodate that difference. But over time, this puts wear and tear on the pelvis and the lower back, and that can travel even right up. And it can cause spasm and in the back muscles. So this is something that OTs and physios are very, very helpful with. It's managed very well by them, doing things like strengthening abdominal muscles and mobility aids, etc. And important to use mobility aids properly. And this is another one, I think, where it's very common in terms of mobility aids for people to not want to take them because it feels like giving in to the disease. But if we can put another pair of glasses on it and say, this is what I need to get to what I need to get to, it can really change everything. Burning and other sensory disturbances, we talked a little bit about that earlier. This can be used helpful with different medications. The tricyclic antidepressants, for some reason, have an effect in this kind of pain. And some of the newer ones, the SSRIs, have been helpful, helping people with these. And it's not because it's linked to depression, but there's something in the makeup of these medications that interacts with the chemicals in our body to help manage these sensory disturbances. Trigeminal neuralgia, also known as tic douloureux, is a severe facial pain which comes on with chewing, smiling, talking, putting on makeup, just about anything. It affects about 3% of people with MS, which is much more than the population at large. This is usually treated well with medications, and if it doesn't respond to medications, surgery can be helpful. Deconditioning and the impact of exercise on fatigue. So in 2015, a comprehensive study was done looking at 36 different trials. Overall, composed of 1,063 people with MS. They found that exercise therapy is a promising treatment for reducing fatigue without side effects. Obviously, it's not a medication, but it can improve fatigue. This finding seems to be especially true for endurance training, mixed training, as in muscle power training or mixed with endurance training, or any other kind of training. Yoga, Tai Chi, anything that you can do on a regular basis will help to build your stamina and improve that problem of fatigue. From a safety perspective, it was reported that in terms of MS relapses, they were no more in the people receiving exercise therapy than the people who didn't receive exercise therapy. There was no difference at all. So even though heating up may cause a sort of a little bit of weakness, it should recover on cooling and rest, and it certainly doesn't cause attacks that would have happened. There's no relationship of increased attacks to that kind of heating and transient weakness that can happen. The BMC is the Boston Medical Center. Their journal in 2015 summarized that appropriate exercise can cause noteworthy and important improvements in cardiorespiratory fitness, muscle strength, flexibility, balance, fatigue, cognition, and quality of life in MS. So exercise can be considered a very safe and effective means of rehabilitation for people living with MS. Existing evidence shows that supervised and individualized exercise program can improve fitness, functional capacity, and a quality of life, as well as modifiable impairments in people with MS. Things, of course, to keep in mind. Safety first, that's really important. So if you have problems, for example, with balance and standing, seated yoga can be very effective, and you can burn up a sweat doing seated programs. Try seated resistance training, for example. If you're weaker when you're overheated, as I mentioned earlier, just tailor your program appropriately. Try swimming, low-impact water aerobics. The cooling effect of the water, plus the amount that it lifts and supports you, can make it easier to do. And if you look up the calorie content, if you put some energy into low-impact water aerobics, you're actually burning an awful lot of calories. So it has a lot of gains if you can find a way to take advantage of that. Or walk early in the day before it gets too warm. So it's a matter of sort of knowing what your limits are and working with them. Improvements will, remember that improvements will fade quickly if you discontinue the routine, though. There are some medications used for fatigue and MS. Amantadine or Simitril is probably the oldest one. That's given 100 milligrams twice a day. It's suggested that you take that second pill not later than 3 o'clock in the afternoon, or it may keep you up at night. Modafinil, and I apologize, I can't remember the other name for that. Allertec is another one that's taken just in the mornings. I mentioned Ritalin here because some people are on it. At our center, we don't use it. It's very habit forming and just not a good choice when there's other things to try. So Ritalin, I believe, is also taken twice a day, the second dose not later than noon. And yes, it is the medication that's used for calming down active children, hyperactive children, children with ADHD, and focusing their attention. But that's in adults, it has a different effect, and it actually works as a stimulant. So the things that I've talked about so far are really about empowerment. I've tried to suggest some things that you can look into, that you can take advantage of. Only you know what it feels like to live with your fatigue, and only you can change the toll that fatigue takes by tapping into the help that's around you and seeing what works for you. So I like to use a little bit of a bank analogy here when we think about energy and planning. Obviously, the funding, where do we get our energy from? If we think of energy as a resource, we pull it from adequate rest, good sleep hygiene, healthy diet, limited caffeine intake, promote and protect me time, that's you time, special time just for you, mobility aids if indicated. And where we always say it's about the journey, not the destination? In this case, it's actually about the destination. It doesn't matter how you get there, but if the mobility aid allows you to get there, then that's actually taking charge and getting out there and not letting MS hold you back. Some people wake up feeling like $1 million. I wake up feeling like insufficient funds. And we all know that happens to all of us once in a while, but it sure shouldn't be a way of life. So when you know what your energy stores are, you can kind of budget. And so typically, the priority, the big percentage goes to work, family, responsibilities, home needs. But are you having fun? Fun is restorative, and try to hold a little something back that's just for you and to make sure that you're getting some enjoyment out of life. I've thought about the rule of fives for budgeting, and I apologize if you can't see this screen quite clearly. And the rule of fives is just an arbitrary kind of number, but when you take a particular activity, and the tendency, of course, for many of us is to say, yes right away without thinking about it. First, when something's asked of you, or something you're thinking you should do, don't make a decision right away. Let's talk about the rule of fives. If I don't do this, will it matter in 5 hours, 5 days, 5 weeks? So let's take a look at attending my son's soccer game. That's always going to matter. That's going to be remembered forever. Memories, wonderful memories come from that. Cleaning the laundry room. Well, yeah, if I don't do it today, it's probably still going to be bugging me tonight. But a month from now, I'm not even going to remember that I didn't do it, other than maybe it isn't done. But it maybe didn't have to be done on that one day. Getting groceries, well, yeah, there are things that we have to do in life that we just have to do. So yes, obviously that's important. So that's going to be something we're going to have to figure into our plan. You get asked by the neighborhood association to make a cake for the neighborhood barbecue. Well, yes, I guess that night you're probably wishing you're doing it. You might still remember a week later, but 5 months from now, nobody's going to remember that you didn't make that cake for the barbecue. And so this is just a little way that I like to suggest people can use for deciding what's important and where they're going to spend their energy. Is there a way to stretch your energy dollar? So let's talk about going to the soccer game. Can you get a ride from another parent? Can you bring a folding chair and a cold drink so you can sit? Or what about a mobility device? If it helps you get there, it's well worth the effort. Cleaning the laundry room, can you do it in pieces over time, bits and pieces? Plan a reward for yourself when you've got it done. Treat yourself to something. Getting groceries, can you break it up? Can you do produce on one day, groceries on another? Can you use a service? And making a cake for the neighbor's barbecue, well, I guess, obviously buy a mix. Ask your kids for help, it's a good skill to learn, or just say no. That's not just for drugs, just say no. The free zone, the MS free zone, I think is an important concept. This is me time where MS doesn't intrude into this. So this is something for you, something you enjoy. MS doesn't make a difference here, whether it's time just with yourself, time with your family, doing some activity. But be sure to keep that high up in that pile of things to do, because this is also something really restorative and it'll bring energy back to you. So to sum up what we've talked about tonight, fatigue is common in MS. It can impact just about every aspect of life, from work to relationships. And there's lots you can do to try and improve the fatigue that you're having. Thank you. Oh, it looks like maybe those slides are somebody else's. I'm done. Thank you.
Okay, April, thank you so much. I learned quite a bit tonight, and I thought I knew everything there was to know about fatigue, and apparently I knew next to nothing. Two things really stand out in my mind. First of all, primary and secondary fatigue. I never even gave that a thought before, and I'm realizing that all of my fatigue is secondary, which means that I have some control over it. And so I'm quite pleased with that, and that's a big thing for me to have learned. Also, I really like the MS-free zone. From now on, that's going to be my mindset when I'm doing something that I want to do for me. It's
Good.
MS-free. So, excellent presentation. We have quite a few minutes left here for questions. So if you do have a question, you can type your question into the chat box, and we'll get to as many questions as possible. So I'm just going to change screens here. Our first question is from Zoom. What exactly does deconditioning mean? This was something you talked about early on in your presentation.
Yeah, so deconditioning just means that your overall stamina, your muscle strength, as you don't use these things, they get weaker, they perform less efficiently. And so conditioning is the opposite of that. And how do we achieve conditioning? Better conditioning, it's through exercise or using them, just using them. It doesn't have to be great, robust, walking around the block 30 times. It can be something as simple as sitting in a chair and using those, elastic bands that we use sometimes in yoga or Pilates, and working your muscles that way. It can be very low key. The important thing is to do something and do it regularly.
And I tell people all the time, move. Every single day, move. If you can only move your
Just
little
keep
finger,
moving.
move it.
Yeah. Move it
People
or
are going
lose
to
it.
get tired of hearing me say that.
No,
Okay.
my dad is 90. Oh, so my dad is 91, and he lives by use it or lose it.
Yeah.
He's still working.
Smart man. Well, I don't know if you should. I don't know how smart he is that he's still working. Okay. So the next question, also from Zoom, is fatigue a symptom to ask for workplace accommodation, especially if there's no place to rest in the workplace? Commuting takes more than an hour, for example, to work from home as the accommodation. So, what would you say to that?
I think that's a really great question. The onus is on employers to do what they can to provide accommodation. Now, I think that for most jobs, it's very difficult for anybody to say that it's impossible to work remotely. We've learned that can work. There also, though, is a perspective of it's important to be there sometimes. So I think, the best thing is to have, if it's possible, a reasonable conversation with the boss. And what typically is most helpful is if you come to it with solutions. Come with some ideas that might work instead of I just can't do this or I don't want this. I think some of the bigger in my experience now, it may be certainly greatly changed with the way life is now, and if anybody has one job, they actually have what used to be 3 jobs. But the big employers like the hydro companies, public utilities, the banks, they tend to have a lot more flexibility in terms of um, making accommodation. But I really think the key here is to come with some suggestions of your own. Maybe it's a staggered work
Mhm.
day, maybe it's a couple of days a week from home, um, and make it possible for that boss to do everything that they can to help you if you go approach it as a team issue.
Yeah.
And
Okay. I should.
admittedly it's not always possible. That's for sure.
No,
Um,
no. I
but
will
they
mention
sometimes
that.
the HR department
Sorry, go
should be
ahead.
able to help in that. Oh, I'm sorry. It's just your HR department, if there is one, should be able to help in that. Now, if you work in the little corner store, there's no such thing. So
Yeah.
um, you just have to see what resources are around that might be able to support you.
Yeah. I used to be able to sneak in a 20-minute to 30-minute break from time to time during my work week if things were really, that much for me. So
And
just
sometimes
sneak
that's
into the
all it
boardroom
takes.
and move to the door. And sometimes that's all I need, like just 10 minutes of
Yeah.
downtime, nobody talking at me, no phones ringing, nothing.
Yeah.
Okay, our next question from this person says, I actually sleep really well. No insomnia, no sleep apnea, no depression, but I'm fatigued all the time. Not a take a nap tired, but a full body fatigue. Who do I see about this? My GP?
You can start with the GP, but that might, if you go to an MS clinic, it might be worth talking with them about it, because they'll be a little bit more familiar with, the things like the medications and things, or the other MS things that could be contributing. I think it's unusual that the fatigue is purely central fatigue. I think it's more commonly a whole host of things. And so the MS clinic can be very geared, particularly occupational therapists actually, or even doesn't have to be the clinic, an occupational therapist your GP could refer you to. They're also very effective at finding energy saving ways to live.
Okay. Somebody would like to know more about how those medications work, like amantadine and modafinil. I know modafinil was used specifically for narcolepsy, and amantadine early on developed for as a flu prophylactic, I believe, or respiratory virus prophylactic.
So yeah, amantadine is an antiviral, and it's a kind of just a curious finding, much like remember it was a heart medication that years ago that they were using Rogaine.
Rogaine.
And they found that men who had baldness were growing hair again. So that's the same situation with Simitril. They found in nursing homes, I believe, that where they were giving this as an antiviral medication to protect these elderly people, that they were getting less. They were finding that they were having a little more energy. But I did jot down because I'm not familiar. I did jot down about modafinil today, and I meant to say it, and I didn't. I'm sorry. Um, yeah, modafinil. Well, it makes sense. Allertech. It's a central stimulant, so that's really all I can tell you. It works centrally, um, and and Ritalin too is a central stimulant. So these drugs just all have some kind of effect on the central nervous system. I know amantadine and modafinil tend to be quite well tolerated and considered safe, but I
Yeah.
really don't know anything about Ritalin. We just don't use it.
Yeah, and I can speak from personal experience about both amantadine and the modafinil, and I found them both very effective when I use them. So,
It's
but that's
very
just me.
interesting. There's studies that years ago I worked on a study, um, supported a study that was looking at amantadine and MS, and the study had a negative finding that it didn't do anything. And studies on these drugs in MS fatigue are just all over the place, but anecdotally, people will tell you that it helps. So, that's probably goes back to that thing I said at the very beginning, where the way it's measured, the way people describe it, the way it's tolerated is just so
Yeah.
highly variable. And it's hard to measure, that we get these wild outcomes of studies that just don't seem to line up. But I think, as I used to say to patients in the clinic with amantadine, you can try it for a couple of weeks, do your own controlled study, try it for a couple of weeks, go off of it for a couple of weeks, and make some notes, and then go back on it and see if you notice a difference. That's your answer.
Good idea. Okay, is there anything to specifically help with fatigue because of drop foot or shuffling?
Yeah, so that's fatigue from just effort, right? Just that's so much effort and
Yes.
so hard to do. So Drop foot is a splint. There's a number of good orthotics around. Maybe some gait assessment and training can be helpful. But anything like that, particularly in orthotic, will help to lift the foot yourself, and you're not putting as much weight into hiking it up from your hip and swinging it around. That's really, really exhausting. And over time is a lot of wear and tear on your back.
Okay, here's a great question. Does Botox work for bladder spasticity that may keep you up at night and increase fatigue?
It can. There are places that are using Botox on bladder, and if it improves the storage capacity of the bladder, that will improve your sleep. And yeah, so for sure.
Okay, and along similar lines, are there so-called alternative therapies or natural products or supplements, vitamins that might be beneficial in counteracting fatigue or helping with sleep?
People talk about, in fact, I've tried it myself and I can't think of the name of it. Oh, Shauna.
Melatonin?
Melatonin, thank you. Yeah, some people find that quite helpful. Memory is the second thing that goes. People have said that that's helpful. Chamomile tea at night can be helpful. You know, a lot of this is about routine. That's really the key here. Chamomile, be a little careful because chamomile is related to ragweed. And so if you've got hay fever, chamomile may not be the way to go.
Yeah.
But green teas are very soothing. And in terms of supplements, I believe magnesium, some people use magnesium and that seems to help. We talk to the pharmacist about how it works with anything else that you're taking, combinations with your medication or threshold amounts that you shouldn't be exceeding. But the pharmacist can be quite helpful in that respect.
Okay, well, we're almost out of time here for questions. So, April, I'm going to thank you so very much for your presentation and answering these questions. Much appreciated.
It was a pleasure.
And as we wrap up today's broadcast, we want to remind you about the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. You can connect by phone, email, or live chat through the MS Society's website, and know that the interactions are confidential. The information is trustworthy. Navigators can help you learn more about the programming and resources that we offer. Plus, they can help you find other community or government supports and programs, and they can also get you signed up for the monthly MS Canada e-newsletter, so you can be in the know. And we want you to be part of the MS community, encourage you to get involved with our programs, the services, government relations, events, volunteer opportunities, and there are plenty of them. These days, connecting with each other is more important than ever, and more information is available on the website www.mscanada.ca. Now, if you've got questions or if you need support for this webinar or any of our education activities, you can reach out to the education team, and you can do so by email to education@mscanada.ca. And on behalf of MS Canada, thank you for tuning in for today's webinar. Enjoy the next part of your summer. Bye.